Good morning. My name is Monank Shaw, and today we're going to be discussing antiviral agents. One of the first things to perhaps mention before we even get started is the fact that there's really only a few drugs that you actually need to know, and there's actually only a few antiviral agents in use today. And that's in pretty stark contrast to all the plethora of antibiotics that we have. And so here you see the outline of the drugs that we're going to cover. And this really does represent essentially the full spectrum of antiviral agents. Of note, the agents against HIV virus will be covered in a separate lecture. So today we're going to cover drugs that are in use for influenza, for herpes, for hepatitis B, and for hepatitis C. And it's worth mentioning that there's a reason why we have so few agents out there to target viruses. And the biggest problem is that viruses have a substantial amount of heterogeneity. The viruses have all evolved to develop different life cycles, different mechanisms by which they replicate. And as a result, it's really very hard to find a single strategy by which you could target multiple different viruses. The second problem is that viruses are all intracellular organisms. And as a result, antiviral agents have to be designed in a way that target the virus but leave the host cell intact. And for the longest time, it was felt that this wasn't really possible and that any antiviral agents would also be toxic to the host. And as a result, for a large period of time, the focus for targeting or attacking viruses really focused on developing immunomodulatory strategies or enhancements of your own immune system to clear the viruses rather than developing specific antivirals. The last problem and challenge to the development of antiviral agents is the fact that viruses replicate very, very frequently. And moreover, viruses tend to be very error-prone in their replication systems. As a result, they develop a huge amount of mutations. There's a large amount of viral heterogeneity even within a single individual. And anytime you see that level of viral heterogeneity, that degree of mutations, you can imagine that there is emergence and selection of drug resistance really quite fast. So let's start our discussion of antivirals by talking about drugs that are used against influenza. And we'll just remind everyone that influenza is a single-stranded RNA virus, which still causes a substantial amount of morbidity and mortality around the world, with over 10,000 deaths every single year. And we won't go into the viral life cycle in any detail, but I just want to highlight a few important aspects. First, you have viral entry, which uses the hemagglutinin proteins, and that happens here. After viral entry, there's an important item that occurs, which is that you have acidification of the viral core, and that acidification occurs using this M2 ion channel that you see here. The viral the acidification of the virion then allows viral uncoating, and subsequently you have replication and translation and viral assembly, and eventually viral release. The few pieces that we really want you to know are the fact that viral entry is mediated by the hemagglutinin protein here, that the acidification process and viral uncoating is mediated by the M2 ion channel, and the fact that viral release is really mediated by the neuraminidase proteins here. And antiviral agents have been developed to target specific parts of this viral life cycle. So amantadine and rimantadine exert their effects by blocking this M2 ion channel, but they also exert their effects by preventing or causing alterations in the conformation of the hemagglutinin protein shortly after viral translation. Zanamivir and oseltamivir, on the other hand, work by a different mechanism, and they are neuraminidase inhibitors, which block the impact of neuraminidase and blocks viral release at the late stage of the viral life cycle. So let's look at this in a little bit more detail. So amantadine, as we mentioned, exerts its effects and has its mechanism of action is predicated on blocking the M2 ion channel. And here you see an illustration of that on this slide. Essentially, the amantadine molecule is able to essentially block the M2 ion channel and prevent ions from flowing through this channel, which upsets the balance of trying to acidify the core and blocks viral uncoating. It also has a secondary effect, as we mentioned before, on causing a late stage, which we call a late stage effect, which impacts at the level of the Golgi apparatus and causes a conformational change in the production of viral hemagglutinin protein. When you have altered hemagglutinin protein, you can no longer have viral entry, and that disrupts the viral infectious process. Overall, these drugs are actually quite good. They're able to be taken orally, and they're quite efficacious, but they have some really serious limitations. The biggest problem with these drugs is that there is high-level resistance, and as you might imagine, resistance occurs when you have mutations in the M2 ion channel. And studies have found that within 3 to 5 days of taking this drug, about a third of patients will be able to have detectable viral replication. And currently, there's such high-level drug resistance to both amantadine and rimantadine that they're currently not even recommended for usage, at least with the currently circulating flu strains this current year. The second thing to know about these drugs is that they fairly specifically inhibit the influenza A M2 ion channel, and what that means is that it has fairly little efficacy against influenza B and C type viruses. The other serious limitation is the fact that amantadine in particular can cause quite a bit of CNS toxicity. It can cause everything from seizures to hallucinations, lightheadedness, dizziness, and those are really serious limitations when you're considering the fact that many people will clear their influenza virus on their own with fairly minimal side effects or fairly minimal complications, and so you always are trying to weigh the risks and benefits of using these agents. The next set of drugs, which are in much more common use, are zanamivir and oseltamivir. And this slide simply highlights in a little bit more detail the way in which they work. So at the time of viral release, essentially the virus buds from the host cell, but at the time of budding, it still remains in contact with the host cell via a sialic acid residue. Neuraminidase, which is on this viral envelope, sort of reaches over and cleaves that sialic acid residue bond and then releases the virion to allow further ongoing infection. These neuraminidase inhibitors are mimics or analogs of sialic acid, and as a result, they competitively bind neuraminidase and prevent the neuraminidase from cleaving the sialic acid binding and prevents viral release from the host cell. Neuraminidase inhibitors are nice in that they work against both influenza A and influenza B. In terms of the pharmacology of these agents, they're actually quite well tolerated. The biggest difference between zanamivir and oseltamivir is that zanamivir is delivered via inhalation, and so you use an inhaler essentially to deliver zanamivir. There are some IV formulations in clinical trials, but they're not commonly used. On the other hand, oseltamivir is an oral agent and is for that reason quite commonly used because it's easy to take. Both are actually very well tolerated, but their mode of delivery actually tells you a little bit about their primary toxicities. Oseltamivir can sometimes cause a little bit of nausea and vomiting, usually quite well tolerated. And zanamivir, on the other hand, because it's delivered via an inhaler, can sometimes cause a little bit of airway irritation and stimulate some bronchospasm. So you do have to be careful of using zanamivir in patients that have some reactive airway disease or asthma. In terms of efficacy, they're both approved for treatment and prophylaxis and are actually quite efficacious. But of course, just because they're approved for usage for both treatment and prophylaxis doesn't necessarily mean that clinically they should be used in all situations. The primary benefit really is seen only if you start them within about 48 hours of developing symptoms. And the clinical trials have generally showed that if you're able to start them within about 48 hours, then you have the potential to reduce the duration or severity of disease by about 1 to 2 days. Now, of course, people may argue that that's not incredibly clinically relevant or useful because people are about 1 or 2 days is not a substantial amount of time. And that's part of why there has to be some judgment as to when to use these medications. They're particularly useful in immunosuppressed patients or hospitalized patients. And in those situations, you may derive some benefit even if you start a little bit after 48 hours. When it comes to prophylaxis, it's sort of the same situation, that your primary benefit occurs when you start the drug pretty early after exposure to a high-risk patient. But generally speaking, we reserve prophylactic usage for situations where a patient is at high risk for complications, namely if they're immunosuppressed, sometimes in the elderly or in nursing home situations. And you just have to start them fairly early, otherwise you defeat their purpose. Both of these drugs are active against both influenza A and influenza B, and at least this year, in terms of the circulating viruses, there's actually very little in the way of resistance. Resistance is, of course, a concern as people use these drugs more often, and it has been described in the literature. And the mechanism is primarily, as you can once again probably predict, is via mutations in the neuraminidase protein. So if you have a neuraminidase mutation, essentially these drugs don't bind neuraminidase as well, and their mechanism of action is compromised. Let's now move on to talking about herpes viruses. So herpes viruses are very important because there's a number of them that cause disease in humans. The ones we're really going to focus on in this lecture are CMV, HSV1 and 2, and VZV. And the reason that we're focusing on those viruses is that those are really the main viruses for which antivirals have some efficacy. On this slide, you see the fairly complicated viral life cycle, which we're not going to go into in any detail. We put it there just really to highlight the fact that despite there being multiple different places that you might have designed drug targets or drugs to target, all of the drugs that are currently in use really focus on one part of this viral life cycle, and that is that they all act at the level of viral replication, and they all of the drugs in one form or another target the viral DNA polymerase. And that's sort of in contrast to influenza, which we just saw where the antivirals are targeting sort of an early stage part of the life cycle or a late stage at the level of viral release. The drugs for herpes viruses really target viral replication at the level of the viral DNA polymerase. And the prototype drug that is out there, which is actually quite effective for HSV and VZV, is acyclovir. And the mechanism of action is actually quite simple. Acyclovir is an analog of the nucleoside deoxyguanosine. And the reason it inhibits the viral DNA polymerase is that deoxyguanosine and acyclovir look very similar to each other. And so the viral DNA polymerase sort of preferentially takes up acyclovir. But because acyclovir doesn't have this one hydroxyl group, the next nucleoside is unable to bind to it, and essentially you get viral DNA chain termination. So viral replication is impeded. But probably the most important thing to take home about acyclovir is the fact that in order to work, acyclovir has to be phosphorylated. And you can see that cartoon at the very bottom in which you can see that acyclovir requires a viral thymidine kinase, and that viral thymidine kinase is what phosphorylates acyclovir into this acyclovir monophosphate. After that, some cellular tyrosine kinases take over, and you develop acyclovir triphosphate, and that's what then goes and gets incorporated by the viral DNA polymerase. Now, HSV has of this viral thymidine kinase, but CMV does not. And that tells you something about the spectrum of activity of acyclovir. That acyclovir is very good for HSV, it's very good for VZV, which have these viral thymidine kinases, but it actually has very little efficacy on CMV, because CMV doesn't have that viral thymidine kinase. In terms of its pharmacokinetics, acyclovir is nice because it is available both orally and IV and topically. But the downside of acyclovir is that it has a short half-life, it has poor bioavailability, and so you actually have to dose it up to 5 times a day. There is a slightly different form of the drug called valacyclovir, and that has better pharmacokinetic properties, and so as a result, it is better able to be absorbed, has better bioavailability, and is only twice a day. These drugs are actually quite well tolerated, and they're very efficacious in terms of reducing replication of the herpes virus or VZV virus. It can reduce the duration of disease of both herpes outbreaks and zoster or primary chickenpox. But they do have very little efficacy against CMV. The second thing to know is because of the mechanism of action, which is that it is inhibiting the DNA polymerase, it preferentially works on replicating viruses. And as you might recall, herpes viruses also are often go into a latent phase. And latent HSV or latent VZV are therefore not really impacted by these drugs. So these are not drugs that are going to eradicate the virus from the host, but they will help when you have reactivation or the lytic phase of HSV or VZV. The primary problem with using these too often is that resistance can indeed occur, and because acyclovir requires the viral thymidine kinase for its activity, if the herpes or VZV viruses develop any mutations in the viral thymidine kinase, or if they develop reductions in the amount of viral thymidine kinase that they produce, you can basically have resistance to acyclovir. And that mechanism of resistance really carries cross-resistance for herpes viruses against all of the other analogs of acyclovir, including valacyclovir and even ganciclovir. The other mechanism of resistance, which is less common, is that you actually have mutations in the viral DNA polymerase itself, which allow it to escape its affinity for acyclovir. So the next drug that is important to know is that given that acyclovir doesn't have activity against CMV, it raises the question of what can you use against serious CMV infections. And the drug that we commonly use, and that is the first line for CMV, is ganciclovir. Now, ganciclovir and acyclovir are really very, very similar, and so there's not a lot more to remember. They both are deoxyguanosine analogs. They both need to be phosphorylated to be active, and they both inhibit viral DNA kinase by a mechanism of chain termination. But the big difference between acyclovir and ganciclovir is that within CMV virions, there is a viral protein kinase encoded by the UL97 gene, and this protein kinase actually has affinity for ganciclovir. And so even though CMV does not have the thymidine kinase that HSV has, ganciclovir is still able to be phosphorylated by this CMV viral protein kinase. And after it gets phosphorylated, it can then get incorporated into the elongating DNA chain and cause chain termination. And so as a result, ganciclovir has efficacy against CMV because it has the protein kinase to phosphorylate it. It also has activity against HSV and VZV because HSV and VZV have viral thymidine kinases to phosphorylate it. And so it actually has fairly broad activity against herpes viruses. And this is the drug that is considered the first line for serious CMV disease. Primarily, however, this drug has to be given IV. It can be given orally, but has very, very poor oral bioavailability. Similar to acyclovir, which had a prodrug called valacyclovir, there is another drug called valganciclovir, which is available orally and has fairly good bioavailability when given orally. The reason, however, that we don't use this drug as first line against herpes or zoster is the toxicity. These drugs fairly reproducibly cause bone marrow suppression, and it can cause all of your cell lines to go down. So your white blood cell count can go down, you can become anemic, you can become thrombocytopenic, which is your platelets can be reduced. And because of that toxicity, we really utilize ganciclovir and valganciclovir primarily for serious CMV infections, primarily in patients with HIV or transplants or other forms of immunosuppression. The mechanism of resistance, which is important to know, is that you can have mutations in the protein kinase, which render it unable to phosphorylate ganciclovir. And that's essentially what's known as the UL97 mutations. The important concept here is that similar to the mechanism of resistance for acyclovir, the resistance occurs when the virus develops mutations in their respective kinases, and the drug can no longer become phosphorylated and can no longer become activated, and therefore cannot function in their role as viral DNA polymerase inhibitors. So what do you do when you have serious infections with HSV, VZV, or CMV, and you have one of these mutations conferring drug resistance? That's when we go to our second line agent. And that second line agent is known as foscarnet. Foscarnet also works as a DNA polymerase inhibitor, but it works by a slightly different mechanism. It's not an analog of a nucleoside. Rather, it's a new analog of something known as pyrophosphate. And the key concept here is that foscarnet binds the polymerase as a competitive inhibitor of the pyrophosphate and blocks DNA elongation. So it's a slightly different mechanism of DNA polymerase inhibition than acyclovir or ganciclovir, but it still is working at the level of the DNA polymerase. Once again, you might ask, well, if this drug is able to be active against HSV, CMV, and VZV, and it doesn't have the same level of resistance, why don't we use it preferentially? And it's really for two big reasons. Number one, it's only available IV. So it's logistically not necessarily that easy to use. And number two, it has some very serious toxicities. Foscarnet can cause renal impairment quite commonly, and that renal impairment can be quite serious. You can have reductions in creatinine clearance and electrolyte abnormalities, which can really limit your ability to use the drug. And for those reasons, this is usually considered a second-line agent against the herpes viruses. We're now going to change directions a little bit and talk about the hepatitis viruses, hepatitis B and hepatitis C. And there are a handful of drugs which are efficacious against these hepatitis viruses. Now, hepatitis B and hepatitis C are quite different. Hepatitis B is a DNA virus, whereas hepatitis C is an RNA virus. Despite that difference, there is one drug that is actually used in both viruses, against both viruses, and that drug is interferon. And the fact that interferon has some efficacy against these two very different viruses tells you something about how interferon works. Interferon really is not a virally specific agent. Rather, interferon, as you may recall from immunology, is a cytokine. And interferon exerts its antiviral properties by serving in many ways as an immunomodulator. So it stimulates your immune system to try to clear the virus. The other drug of interest here is lamivudine. Now, lamivudine is active against both hepatitis B and HIV. And in fact, you will hear quite a bit more about this drug when you get your talk on anti-HIV medications. Lamivudine works as a reverse transcriptase inhibitor, and I think this is quite an interesting mechanism of action for in its effects against hepatitis B, because hepatitis B is a double-stranded DNA virus, and lamivudine is a reverse transcriptase inhibitor. And the reason lamivudine has activity against hepatitis B is the fact that within the viral life cycle, hepatitis B proceeds via a RNA intermediate. And essentially, the DNA gets converted to RNA first, and then after that, the RNA gets converted by this reverse transcriptase back into DNA. And that's where lamivudine does its work. So let's look at these two drugs in a little bit more detail. So going back to interferon first. Interferon is a cytokine, and you don't need to know all of the details of how it works because a lot of those details are unknown and unclear. Interferon probably stimulates some various host interferon-specific response elements, which leads to at least a dozen different proteins being expressed, which help aid in viral clearance and really have their effects at almost every stage of the viral life cycle. In terms of its pharmacokinetics and how we use it and its efficacy, interferon is usually given in its pegylated form, so you'll hear the term PEG interferon quite commonly. It's given for a fairly predefined period, and that's one of its benefits. So unlike some of the other drugs, you give interferon for a specific period of time and then you stop. And you get, in patients with chronic active hepatitis B, you can get about a 30 to 70% response in terms of viral suppression or improvements in liver enzyme function. And it's usually given in combination with lamivudine. The downside of pegylated interferon, however, is that it can make you feel quite lousy. You can get myalgias, a number of flu-like symptoms. Occasionally, it can cause some bone marrow suppression as well. The other problem with it is that it doesn't necessarily lead to a long-term durable effect, and some people will relapse after having had even a long course of interferon therapy. Lamivudine, which is also known as 3TC, and that's an abbreviation that you will actually hear quite often on the clinical wards. We often refer to it simply as 3TC. Is a nucleoside reverse transcriptase inhibitor, and its mechanism of action is quite analogous to that of acyclovir or ganciclovir in many ways. It is a nucleoside analog of cytosine, which works by inhibiting reverse transcriptase by acting as a chain terminator. Essentially, lamivudine gets preferentially taken up by the reverse transcriptase, and the reverse transcriptase, in its role as an RNA-dependent DNA polymerase functioning in trying to go from RNA back to DNA, the lamivudine essentially blocks the DNA elongation by functioning as a chain terminator. Once again, you'll hear about this drug quite a bit more when you have your lecture on antiretrovirals, because this is a key drug used in HIV infection as well. It's really a very nice drug in terms of its safety profile and in the way it's given. 3TC is orally administered. It's renally cleared, so it does have to sometimes be renally adjusted if people have renal impairment, but it actually has very few side effects. It's very well tolerated, and so it's quite easy to use. The biggest limitation with lamivudine is the fact that you can get quite a bit of resistance. And the resistance mechanism is that you develop a reverse transcriptase mutations. For hepatitis B, that mutation is known as the YMDD mutation. And I'll just mention that that is a different mutation than one that you will commonly hear in use when you get your HIV lectures, which is the M184V mutation. In terms of the efficacy of lamivudine against hepatitis B, similar to interferon, you can get about a 60 or 70% response rate in patients with chronic active hepatitis B. The problem with this drug is that its long-term durability is poor. And so within a few years, more than half of individuals with chronic active hepatitis B will actually develop some viral rebound. And for that reason, it's not a drug that is going to necessarily lead to sustained viral clearance. And you really have to think about your goals of therapy when you use this drug in terms of trying to achieve some level of viral suppression or simply halt progression of additional liver enzyme elevations or hepatitis. We're going to end with a brief discussion of the drugs being used for against hepatitis C virus. We've already mentioned interferon. Pegylated interferon has pleiotropic effects against hepatitis C and for the longest time has been a mainstay of therapy for hepatitis C. The challenge with interferon for hepatitis C is that the response rates are actually quite poor. Individuals with hepatitis C genotype 2 and 3 can have fairly high-risk sustained viral response rates on the order of 70 or 80%. But for genotype 1, which is the most prevalent form of hepatitis C in the United States, the response rates to interferon are actually quite poor, on the order of 10 to 30%. Interferon is almost never given alone when you're treating hepatitis C. It is always given in combination with another antiviral agent named ribavirin. Now, ribavirin is a purine nucleoside analog that has fairly broad antiviral activities against many different RNA viruses. But there's not a lot to know about ribavirin, and I say that because the mechanism of action is actually quite unclear, and some of the hypotheses are listed on the slide there. Ribavirin is given orally when you're using it in combination with pegylated interferon for hepatitis C treatment, and its primary toxicity is one of anemia. I should mention that the inhaled version of ribavirin is sometimes used for serious RSV infection, particularly in immunosuppressed patients, including organ transplant patients. Its efficacy for RSV is somewhat unclear, and its usage for RSV is often very logistically challenging because RSV is actually a significant teratogen. And so if you're trying to administer inhaled RSV or inhaled ribavirin, you have to be very careful about aerosols being breathed in by, for example, pregnant healthcare workers. And so delivery of this agent can be quite challenging. And oftentimes the efficacy, as I mentioned, for RSV infection is still a little bit unclear. I want to end, however, on a high note, which is to say that there is a lot of excitement in the hepatitis C world because of the development of two new drugs named telaprevir and boceprevir. And these drugs have the potential to completely revolutionize hepatitis C treatment altogether. Whereas the response rates to pegylated interferon with ribavirin for hepatitis C genotype 1 were relatively poor, these two new drugs are very effective against hepatitis C. And its mechanism of action is that they are both protease inhibitors. And you'll hear the term protease inhibitor again when you come to HIV antiretroviral drugs. And on the right-hand side of this slide, I've just sort of highlighted the stage of the viral life cycle to take note of. Hepatitis C is interesting in that after you get translation of the hepatitis C RNA and you initially have the development of a very large polyprotein. That polyprotein has to be cleaved into a number of smaller proteins, and that cleavage event is mediated by a viral protease. And these two drugs serve as protease inhibitors. And essentially, you therefore don't get this cleavage event of this polyprotein, and you therefore don't have the development of the needed structural and non-structural proteins for the remainder of the replication of the virus and the rest of the life cycle. In clinical trials, these drugs have actually been very well tolerated. They're administered orally, which is a substantial benefit compared to the administration of interferon, which was intramuscular or subcutaneous. There have been reports of mutations which could compromise these drugs in the future, but at the moment they appear to be very efficacious, and they've only recently been FDA approved in the last few years, and so our experience using them is really building, but it has really ushered in a really exciting new era in the management of hepatitis C infection. This final slide is simply a summary slide for your benefit and to try to pull together the list of antiviral drugs that we have discussed. We initially discussed drugs against influenza. Those were amantadine, oseltamivir, and zanamivir. We then talked about the herpes virus drugs, acyclovir, ganciclovir, and foscarnet. And we ended with a discussion of some drugs against the hepatitis B, namely lamivudine and interferon. And we briefly introduced two new agents that are being used for hepatitis C infection, and those are boceprevir and telaprevir. Thank you very much.